Tonight. My name is Rick Laughlin, and I work in orthopedic surgery. I'm on the faculty of the medical school, and our practice is spread out throughout the city. We do most of our hospital work at Miami Valley Hospital downtown. Just to give you a little bit of the history of the building, the medical school's been here for around 30 years, and they used to have a practice plan out here in the building that's become the new medical school. And that's that white building, or some of you may have read the paper, that's White Hall. And that used to be a practice facility. And so for a period of time, we didn't have any place to see outpatients here on campus. And so this building is the product of about 7 to 8 years of planning, and we've had the advantage of learning what we learned from the old building, of what worked and what didn't. And I think the exciting thing about this building is we've merged together several departments so we can provide a lot of services. And the genesis of much of it was driven by the athletic training department. And so the athletic trainers needed much more space, and so we were able to combine our rehab facilities and physical therapy with the athletic trainers, and so that's all on the first floor, and we think we'll be able to provide a great service in rehab for same people that are rehabbing the varsity athletes will be working on our patient population, and so we think we can all learn quite a bit from each other. And we moved into the building about last July, and then so as we've kind of gotten in and figured out where everything is, and we're going to start some educational sessions that we can present to the community, and that's this is the first one of those presentations. We hope to do this on a regular basis and provide educational material to the surrounding community. So I really appreciate you all coming out, and welcome. The presentation is fairly, it's kind of a general presentation, and I hope any of you have questions, certainly feel free to ask them along the way. And so we'll get started. So we're going to talk about just a few things that are very common problems in the foot and ankle. My practice focuses on foot and ankle reconstruction, and there's a lot of problems. I think when people think of foot and ankle problems, usually you focus on the toes, and everybody knows about bunions and hammer toes and things like that, but there's a lot of problems around the back part of the foot or around the ankle that oftentimes go undiagnosed, and they can be cause for a lot of problems and pain, and a lot of times people just live with it. And so there are things you can do for it to make it better. And so the things we're going to talk about tonight is flatfoot, or one of the more common problems with flatfoot, Achilles tendon problems, and then also peroneal tendon problems. And so these are all major tendons that cross the ankle, and oftentimes, like a lot of problems in orthopedics and in soft tissues, start becoming symptomatic around middle age. And so I usually right around the time of when you turn about 40, 45, many of our tendons don't repair themselves as well. And so you get wear and tear problems with some of the tendons, and I'm sure a lot of you have heard of the rotator cuff, and a lot of the arthritis type problems start becoming more commonly presented at that time. And so we're going to go over some of the tendon problems that affect the foot. So in flatfoot, one of the most common causes of a flatfoot is it's there's a lot of different reasons why people have flat feet. Sometimes people are just born with it, and that's just the way the structure of your bones are. This is something that comes about quite commonly, and it's really common in middle-aged women, probably easily 10 to 1 as far as women to men. And the posterior tibial tendon is a tendon that's right on the inside of the foot. and it goes right around the inside of the ankle. It's on the big toe side of the foot. And what it does is it helps support your arch. So when you walk and your heel hits the ground, and as you try and walk over your foot and push off, your posterior tibial tendon is what stabilizes the back of your foot and allows you to push off like that. And so when that tendon fails, your arch starts to collapse, and you can see in the foot here, the foot starts going out to the side, and you see this is the normal foot. And then this one, you can see the heel is a little bit more out to the side, and you see the lateral toes more. And as a physical exam sign, one of the things we teach the medical students and residents is that's called the too many toes sign. So that means when you look at them from the back, their foot is abducted, and you see all their lateral toes. And normally it should look like this guy, so you just barely see the fifth toe. So when you go home tonight, you can look at your husband or your wife, look at them from the back, and see if they got the right number of toes. The typical history is oftentimes people may have a long-standing history of flat feet. They're usually flexible, though. Some people have flat feet where they're real stiff, and no matter what you do, you can't push them back under. But oftentimes these are flexible, and usually the pain, again, is on the inside of the ankle. It's not something that tends to get better. And this is some things in the body we have the ability to heal. This particular tendon, when it fails, it typically doesn't heal. It just continues to stretch out. And when it stretches out, it's like a rope that's got too much slack in it. You know, if the rope's got a lot of slack in it, you pull on it, nothing happens. And so that's basically what happens to your foot, and it changes the way you walk. Oftentimes people may have a bit of a flat foot, and they don't have a lot of pain, and then they may have kind of what seems like a real minor sprain. You step off a curb somehow or something like that, and that's just kind of like the straw that breaks the camel's back, and then that tendon fails. You get swelling around your ankle, your arch collapses, and then you'll notice the asymmetric progression. So one foot gets more flat than the other. You know, as you look down at your feet, and when you get out of the shower, one's more flat, and like I say, the toes go out to the side. So physical exam, again, we talked about this a little bit before. See how the heel's out to the side, and usually you're tender right on this inside or the big toe side of the foot, right behind your ankle. And the other thing that you find is that commonly when we examine people, we ask you to raise up on your toes. So as you raise up on your toes, you should see your heel invert, and again, that's testing the function of that tendon. And so usually once you get a foot like this, if you notice, if this person stands on their left foot, they can't raise up on their toes independently, and that's what that tendon does. So there's the heel raise, and you see as he goes up, his heel goes in a little bit. And so people who have that, you see this person, again, they got all those toes to the side. You can't see their big toe. You can see the big toe on this other side. And so when that tendon doesn't work, you get kind of chronic swelling around the ankle. People notice that they're weaker as far as with their push-off. And it's usually an activity-related pain. Usually, all you need is an x-ray. I think one thing that's common, and I don't mean to make this into an economics talk, but I know many of you have to start watching how you spend your healthcare money. And this is not a condition that requires an MRI to get a diagnosis. You basically just need a physical exam. And MRIs are ordered a lot for a lot of problems, but in the foot and ankle, I think there's a few things where they're helpful, but for the most part, usually you really don't need an MRI to make a diagnosis. And so MRIs are extremely helpful in the shoulders and knees and in backs, but in foot, they're not usually all that helpful as far as making a diagnosis. So if someone orders an MRI of your foot, ask them if you really need it that much, or especially if you're paying for it out of your health savings account. So what we look for on the x-ray, though, you just need an x-ray with you standing. And this is your tibia, or your leg here. This is your calcaneus. And then you're looking at your medial arch. And you should have these bones should all line up pretty well. And you can see on this side the difference is you've got a sag. And so what your posterior tibial tendon does, it comes down here and it attaches right here to this bone. And so when it's not working anymore, these bones start to sag. And then you get the deformity. So again, what we see is these are just some of the structures that give away. The posterior tibial tendon. Spring ligament is a ligament on the bottom of the foot, again, that helps support the arch. And then the deltoid ligament is the medial ligament of the ankle, and that helps keep the heel centered under the leg. And this is what you get. This is what we've been talking about. You get abduction through the forefoot, hindfoot valgus. That refers to that angulation of the heel. And then usually the medial side of your foot, or the inside, the big toe side, is very mobile. So you can move it up and down wherever you want. And one of the ways I usually describe it to patients, you think of your foot as like a three-legged stool. So if you have three legs, being your heel is one, then your big toe side is one, and your small toe side is the other. And when one of those legs gives out, meaning the medial side, then the three-legged stool starts leaning over to the side, and that's what happens with your foot. So we divide it into stages. So it's a pretty simple classification. The stage 1 means there's no deformity. It's just the tendon swollen and it hurts, but your arch hasn't collapsed yet. And oftentimes, this is where you want to catch people, because a lot of times if you get them in some type of brace or arch support that protects the tendon, and then you do some physical therapy, over 50%, usually 60, 70% of the people their symptoms will go away and they may not need anything else done. And so usually you don't need surgery at this stage. And honestly, I rarely see people at this stage. I think usually they just don't get a diagnosis, and usually they haven't noticed any deformity, so they're either seeing their family physician or taking some Motrin or doing some of the simpler things. So oftentimes I don't see them at this stage. And then the stage 2 is when you're starting to get a deformity, but it's flexible. So you can put a brace on those people and you can kind of push their foot back into the alignment where it needs to be. There are lots of different kinds of braces. That's just one type of brace. We can make some of the braces somewhat cosmetic so they fit inside your shoe, but when you are wearing a brace, you're going to have certain shoe restrictions. Usually these types of things don't fit in any type of shoe. You're usually going to wear an athletic shoe or kind of a walking shoe with it. And again, for the pain and swelling or the acute phases, you help immobilize it with some type of brace, and then you get them into physical therapy. And probably the hard thing to explain to people is you do that to take care of the symptoms, but the tendon typically doesn't heal. So if the tendon gets stretched out, it's not going to heal and go back to its normal length and support your arch. And so what you're trying to accomplish with the brace is to just prevent the deformity from getting any worse and to take care of your symptoms or support the tendon enough so that your pain goes away. But it won't typically control your deformity. So when you put the brace on, you're trying to prevent the tendon from elongating and prevent the arch from collapsing more. There is surgery for it, and oftentimes before you get to the surgery point, probably the take-home point or the most important thing you can do is maintain the flexibility of your foot. So usually when I see people in stage 2, I tell them it's really important to keep all the range of motion of your foot. If you can keep your foot very flexible, then it's easy to brace or easy to put an arch support in, and a lot of times your symptoms will be okay. You start getting a lot of symptoms when as your foot collapses and you start getting a fixed deformity where you cannot bring your foot back into the normal alignment for you to walk on it. And usually as you start getting stiffer, usually you have more symptoms then. And so in the stage 2, again, usually one of the first things I do with people is send them to physical therapy and have physical therapy really work hard on their range of motion and try and get their flexibility back. And then depending on how their symptoms respond to that, and also some people just don't really want to wear a brace long term. And so there is surgery to reconstruct the tendon. And there's different kinds of surgery, and I'm not going to go into too much detail on what the surgery is. The part of the surgery that people have to realize is not a surgery that's just you go in and get it fixed, and a week or two later you're good as new. I mean, it's a surgery that reconstructs your arch. So it's the equivalent, at least in my practice, I tell people, for me, this is like doing a knee replacement or a hip replacement or something like that. It's a surgery that you come in the hospital for. Usually people stay overnight, one night, and there is some recovery time involved in it. And you can either try and preserve the joints or try and preserve the motion in the joint, where we do osteotomies, meaning you cut some of the bones and you realign them, and then we fix and repair the tendon, and we transfer another tendon in to augment it. And that generally works pretty well in younger people who have a very flexible foot. As you get stiffer, so if the foot's not really passively correctable, you can't passively correct it, then we start usually getting our correction by fusing some of the joints. And so we'll go in through the joint, put the bones back where they belong. We usually put some screws in, hold it, and then let those joints fuse. And then your foot's straight. It still works where it goes up and down and pushes off, but you lose some of the side-to-side motion. And so we do those usually in the people who've become stiff and you can't get their motion back. This is just an example of one of the ones with the osteotomies. So this shows in the x-ray the medial column of the foot's been stabilized with some screws, and then we cut the heel bone, shifted it over, and you fix that with some screws. And again, what you're doing is realigning the arch, and then what you can't see is what we do with the tendon. So the tendon we fix, which is right along here, it attaches on this bone, and once you make a new tendon, the soft tissues will help support the arch. And then in the fusions, you see a bunch of screws in this, but basically we go through these joints. The joints had collapsed through this is called the subtalar joint and the talonavicular joint. And so once those collapse, you go in through the joints, you bring the heel back under the talus and line up the medial column. You scrape the joints out, you put screws in, and then it stays straight. And that's a good way for correcting deformity. You do lose a little bit of the side-to-side motion of your foot. So that's kind of flat-foot or posterior tibial tendon disease in a nutshell. Now we're going to go to, anybody have any questions about that? Yes?
What do you do to prevent this? I mean, at a younger age, is there anything you can do, any kind of exercise you can do that prevent this from ever occurring?
I think it's really important to keep your calves well stretched out. So when you go walking or when you work out or things like that, every day you should work on stretching your calves. Certain people are probably more prone to it, people who have a lot of ligamentous laxity. And so maintaining the side-to-side range of motion in your feet is important. There's not a lot of evidence to show that arch supports make a difference or prevent it. But I don't know that that means that they don't work. I just think we haven't done the studies well enough, or you need these huge numbers of people to really show that it makes a difference. But arch supports intuitively probably help. But probably the most important thing, keeping the mobility of your foot, supporting the arch, stretching your calves out, keeping your weight down helps. And some people, again, there is a genetic component to it, and it's amazing when you see a lot of patients. It's amazing that you'll see people who have arthritis in their shoulders, hips, and knees, and I mean they're just kind of genetically predisposed. And I think that's the same with tendons. It's really common to see people who've had both shoulders done or both or they get this on both sides. And so I think there is a little bit of a genetic component that you really can't change much. Did you have a question over there?
Yeah, how common is
How?
this? And how common is this condition? And typically around what age does it occur? What age range?
I think it's very common. I think it's oftentimes underdiagnosed. So we see it's much more common in women. Usually the typical age is probably 50 to 65. And typically a lot of people they just have a swollen ankle that kind of hurts. And, you know, I'll see people who've had just all sorts of testing. I mean, they've been checked for blood clots, they checked for, you know, they get nerve tests, they get checked on for all sorts of things. And it's not really, I usually don't see them until they start developing a deformity. But it's diagnosed usually by physical exam. It again presents in middle age and much more common in women. Yes? I'm sorry? No. No. Venous insufficiency relates to just the blood flow out of the feet. And it doesn't really have much, that really doesn't have much to do with any of the ligaments or the bones or the musculoskeletal system. That's more of a vascular problem. But that's a really common cause of swelling around the ankles. And again, I think a lot of times people present and they have swelling around both ankles, and people say just that. They say you got varicose veins or you got bad circulation in their legs, and there's not much to do for it. But usually that doesn't hurt a lot. So if you have pain that you can localize to one section of your foot, that should tip you off that it's probably more than venous insufficiency. Now you can have both. Yes? I think it contributes to your balance. So kind of like the chicken or the egg. I mean, I think balance, I think when you have this, you don't have as good a balance. Yes?
So, are there exercises that would be preventative, say, either at any age or?
I don't know that they're really preventative. I think they can make the condition not affect you as much. But again, I think there are some genetic factors and just factors that have to do with just the way the structure of your foot was made that make you more prone to get tendon failures. It's just like people with fair skin are more likely to get a sunburn. I think there's certain people that have just the way their tendons and the structure of their foot is, that they're more likely to do this, have this. Yes?
What is the percentage of the operation of recovery with a fairly good motion of the ankle?
Depends on what operation you have. So usually I tell people my main goal of the surgery is to have your foot straight, have it fit in a regular shoe, have you off of pain medicine, and if you need an arch support, it's just one of the over-the-counter ones, like a Dr. Scholl's or something like that. So those are usually my goals of the surgery. But generally, especially if you do the fusion, I mean, you take away some of the side-to-side motion of your foot. Most people don't notice it that much because by the time they get the surgery, they've already lost that motion anyway. So what you're doing is you're restoring the alignment of their foot, and if you differentiate the foot from the ankle, what you're trying to do is line the foot up in the best possible mechanical alignment so your ankle joint doesn't wear out. Another application that I see fairly commonly is people with who have knee replacements. So if you have knock knees, you've been like this for a long time, and then they replace your knee, they straighten out your knee. And this puts more stress on your foot, and sometimes your foot that didn't really hurt before now hurts because the alignment of your knee is different. So the emphasis is, again, restoring the alignment so that it's in the best mechanical position so that it'll last the longest. Yes?
So if you've had an injury to that tendon that was typically removed, it's not likely to probably ever
Oh, I'm sorry. So the question was, if the tendon's been injured, does it ever go back to normal? I think there's two ways to look at it. If you're young and you have a normal foot and you have an acute injury, oftentimes that may calm down. If you have a degenerative, if the tendon stretches out and degenerates, usually no matter what you do, the tendon's not going to heal. So so even every once in a while we'll get somebody who's younger and has an acute injury, and you diagnose a posterior tibial tendon tear. Even in those cases, you rarely just repair it. You usually augment it with something. Yes, sir.
In runners, do you see it more in one foot than another? Or do you see it in runners?
He asked if you see the condition in runners, and probably not as much. It much more common in more of the sedentary middle-aged female, but runners can certainly get tendinitis of their posterior tibial tendon. And again, usually runners, depending on how serious they are, usually you can, runners usually who are highly motivated and run a lot, they'll do a lot of stretching and keep their foot very mobile, and you can usually get it to calm down with arch supports. Okay, so we'll go on to Achilles tendinosis. So everybody knows where your Achilles tendon is, right? It's on the back of your ankle and inserts on the back of your heel. There's kind of two areas that get involved. One is right where the Achilles attaches to your heel bone or your calcaneus, and that's probably by far the most common type of tendinopathy. And then the other one is up in the mid portion of the tendon, and that you see more commonly in the real active people. And to your point, it's common to see that in runners. So again, the physical exam, the nice thing about the foot and ankle is it's very superficial and it's right under the skin. So usually if you know the anatomy and you can poke around and figure out what hurts, you can usually figure out what the problem is. And again, it's usually tender right where it attaches to the bone. Oftentimes, again, this is not one where you need an MRI scan. Usually you just get a plain x-ray. And about the most you'll see on an x-ray is that, see, this is the heel bone here in these two pictures, and you see calcification going up into the tendon here. And that's typically what people get referred to as a bone spur. And what a bone spur really is it's where the tendon attaches to the bone, it's had these micro injuries, or it's wearing out, and your body's trying to make it heal. And as your body tries to heal it, it lays down calcium, and then you get the bony overgrowth, or what you feel is a spur. A lot of times what you actually feel on your heel, though, is mostly soft tissue swelling. So you can see, you can have a really big bump on the back of your heel, and you think you should have this huge bony spur, but usually it's all soft tissue. And the spur usually isn't that big. So in this, again, most of these things, our first approach is non-surgical, and so we do a lot of physical therapy with the foot. You want to modify whatever your activities are, usually anti-inflammatories, things like Motrin or Aleve. Putting a little heel lift into your shoe changes the pull of the muscle, and so sometimes that'll relieve some pain. It also, for people who have a bump on the back of their heel, it raises your foot up in the shoe so that the back of the shoe just hits you in a different spot. And sometimes that'll give you some relief. We do a lot of stretching, and then you can get a pad, these gel pads you can buy that have, has a sock that has a little gel pad inside it, and so you pull that on, and it puts padding right on the back of the heel so that the back of your shoe doesn't rub it. One of the great things is that when I first started practicing, and you kind of see how shoe styles have changed, and one of the best things for me has been these open back shoes. So that when I first went into medicine, nobody wore those. I mean, they were just kind of odd clogs, and nobody ever wore them. But now they're all over the place. And so if you have this problem, usually you can get a little bit of varying heel height and you get an open back shoe that doesn't rub on the area, and a lot of times that'll give you some symptomatic relief. Whoops. This is one that we use cortisone injections for a lot of different things. This is definitely one you do not want a cortisone injection in your Achilles tendon. It increases the chances of you rupturing the tendon. So stay away from injections. I had 2 people come in last month that had cortisone injections in their tendon and they ruptured them. Cortisone wipes out the inflammatory response, and whatever healing response you have is wiped out, and then it also weakens the tendon. So cortisone injections are okay for painful joints when you have like a knee joint and you have arthritis in your knee, but a lot of people will get them in their shoulders, but you need to use them judiciously. So we don't need to get too deep into the classification, but what we're saying about the tendon is here's normal tendon as it attaches on your heel. Sometimes it can be involved in the mid portion of the tendon. The tendon can just degenerate. And what I usually tell patients is like a rope that starts fraying. And so, you know, when you think of a rope, when it starts fraying, it gets wider. And that's what happens to the tendon. So you have all these longitudinal fibers in the tendon, and as they get inflamed and start breaking down, they usually get wider. And that's what you feel when you feel the nodules or the bumps in your tendons. So there's an area of the tendon that has a poorer vascular supply, and it's right here, about usually 1 inch to 2 inches above your heel. And that area doesn't repair itself as well. And you see this, and the reason people get tendon problems when they get into middle age, and there's several tendons in the body that tend to fail, and it tends to be in areas where the tendons don't have as good a blood supply. And so all our tissues need nourishment from the blood, and when they can't get as good a blood supply or the nourishment, they don't repair themselves as well. So again, this is 2 to 6 centimeters above the heel. There's fewer blood vessels, and so there's less capacity for it to heal. Again, people with tendinosis is up in the body of the tendon. They tend to be runners, oftentimes a gradual onset, and they're tender throughout the length of the tendon. Again, usually we don't need a lot of diagnostic studies. The MRI doesn't give me a lot of information. As long as the tendon is working, it doesn't give me a lot of information in how to treat it. And the MRI, they're very sensitive, so it'll tell you what the full extent of any involvement of the tendon. And usually the MRI will make things look much worse than they really are. And so you have to be careful with what you, an MRI is nice to see, but you have to be careful with what you take away from it, because it's such a sensitive test that again, it makes the condition look worse than it probably really is. So again, the surgery for it is usually just debriding the bad part of the tendon, and then kind of in a nutshell, the more you take out, sometimes you have to reconstruct the tendon defect that's created by taking out the bad tendon. So we usually do a longitudinal incision and remove the tendon that looks bad, and then repair the rest. And occasionally we'll take another tendon from the area to reconstruct it or reinforce it. This just shows you a little bit of, so this is an MRI. This shows you kind of some of the diseased tendon. And then this is looking at it in surgery, where you see the tendon here. We've made an incision along the medial side of the tendon, and you cut out the bad portion of the tendon. And if you take out more than 50% of the tendon, we usually reconstruct it with something. And if you take out less than 50%, you can usually just sew it up. Surgical recovery is similar to Achilles tendon rupture. If you don't have to take more than 50% of the tendon, usually the recovery is a little bit faster than a rupture. Again, we usually have you in one of those protective boots and open back shoe for about 3 months, and then usually it takes you probably 8 to 12 months to really get all of your strength back. So the worst part of the surgery is usually about the first 2 months. And you're kind of gimping around for the first couple of months. And then after that, from month 2 up until a year, you're basically just regaining strength. For people who run or do heavy exercise, usually you're back to light jogging around usually 2.5, 3 months. But you're not at the point, like if you're a 10 mile an hour, 10 mile a day runner, you're not doing that for probably a good 8 to 12 months. So the treatment that's kind of in between, this newer that we've been doing, and we have a study going on it, is this stuff called PRP. And what PRP is called platelet-rich plasma. And basically the appealing thing about it is that it's your own tissue, so you don't have to get anything from anybody else. And the way it works is we get draw blood from you just as if you're getting any type of routine blood work. You take your blood and you put it on one of these centrifuges, and the centrifuge spins it down and it isolates the platelets. And the platelets are a cell that's in your blood, and the way it works is there's a lot of growth factors inside the platelets. And so we take that concentrated part that concentrates down to usually about 3 or 4 cc's, and then we inject it directly into the tendon. And so you're putting the growth factors into the bad part of the tendon, trying to incite a healing response. And with the growth factors, then the tendon will somewhat repair itself. We think that it works well. It's been used, platelet-rich plasma, and used in a lot of areas in the body, and in a lot of soft tissue places and in places that haven't typically healed well. And so so far our results have been pretty good, and I'd say of all the people we've done, haven't done surgery on any of them. So far it has prevented people from taking the step to saying they need surgery. And obviously the advantage of this is there's essentially no recovery time. So you come in, and we usually do them on Fridays, and you put ice on it over the weekend, and then by the next week you're walking again, and you can go back to your regular exercise program. So I usually tell people this is something that's very low risk, and probably worst case scenario is it doesn't work. There's not really a risk of getting an infection, or you don't have any implant in your body or anything like that. And so oftentimes it helps and gets them to the point where they don't need surgery. Platelet-rich plasma is still investigational. Again, a very low risk, very limited recovery time, so you really don't have to stay off of work or anything like that. It's generally not covered by insurance, but the nice thing about it is it's not very expensive. So again, I think it's probably less expensive than buying a pair of orthotics. Now, any questions about Achilles tendinitis? Yes, ma'am. What else have we used the PRP for? When it first came out in orthopedics, they used it in fractures that didn't heal, so for that. But it's been used extensively in rotator cuff surgery, because rotator cuffs are typically a tendon that it's necessary, so usually you don't want to cut the whole thing out, and it's one that has a very poor blood supply, and rotator cuff surgery in general is very difficult to get the tendon to heal. Oftentimes your symptoms will go away, but what we work on, or my shoulder partners work on, is trying to figure out better ways to make the tendon heal. So it's used extensively there. It's been used now as people are injecting, where they put it in tennis elbow, and most soft tissue tendon things. Then the other big application of it was people were putting it in knee replacements, trying to decrease the blood loss. And those are probably the biggest orthopedic applications of it. But really anywhere that you do surgery, the plastic surgeons have used it too, anywhere that you do surgery where you're trying to get some soft tissue tendon or fascia or some type of soft tissue to try and heal, a lot of people have used it to augment the healing. Now the peroneal tendons, this is the last one, so if everybody could stay awake, we'll wrap it up in about 5 minutes. The peroneal tendons are on the other side of your ankle. So they're on, this is a picture showing the peroneal, showing a peroneal tendon tear. So this is the the lateral or the outside of the ankle. So this is the leg up here, the foot's over here, and this right here is kind of your ankle bone, or what you feel on the outside of your ankle. And the tendons are right behind. There's 2 tendons right behind your ankle, and these tendons, when you have trouble with them, they do one of 2 things. They either tear, which is more common in middle-aged people, or sometimes you can have a bad ankle sprain and they pop out of their sheath, and so they'll click over the fibula. So that's a popular thing. It happens a lot in teenagers, and a popular thing that'll drive their parents crazy by moving their foot around. You see the tendon pop back and forth over the tendon. So again, the more common thing we see usually is the middle-aged people with a tendon tear, and usually the pain is behind the lateral side of your ankle bone. And the other thing that's important on this, like on the first part we talked about flat feet. One of the more common alignment things that you see is people with problems on this side of the ankle or the outside of the ankle tend to have a real high arch. So if you have a real high arch and walk on the outside of your foot, you're more likely to get ankle sprains and these tendon tears like this. So this shows a little bit light in here, but this shows the 2 tendons. This is kind of your ankle bone here, and peroneus brevis is the one in the front, and peroneus longus is right behind it. And so in the subluxation, or where the tendons dislocate over the bone, that's usually younger people, it's usually a traumatic event, and it's usually the peroneus longus. So in the tendinosis, where you get just tendinitis or the tendons start to tear, usually what we try and do, again, with a lot of things, you're trying to just change the alignment of the foot. And so you can put a lateral heel wedge in. Usually we do physical therapy. And the reason we use so much physical therapy on these tendon problems is that, one, it helps mobilize the foot, but the physical therapists have a lot of modalities like ultrasound, heat and cold, and all these things that will basically calm down the inflammation of the tendon. And oftentimes, if you can get the inflammation to go away, a lot of your symptoms will go away. So we use a lot of physical therapy and then bracing it so that when you're doing your other activities, you're not stressing the tendon too much. So for in the treatment of the dislocated peroneal tendons, usually there's not a lot you can do to fix that. That's what, I don't know if any of you are baseball fans, but back when the Red Sox were in the World Series and Curt Schilling had his ankle hurt, and they put, I don't know if you remember, but they took him over to the guys at Harvard and they put a big stitch right through his skin and through the tendon. And he had this dislocating peroneal tendons. And they did that so he'd make it through the World Series. His tendons would stop popping, and then when the World Series was over, they went in and fixed it. So that's usually a surgical problem. So there's not really anything you can do to make the tendon stop snapping other than fix it with surgery. The other thing we do with the peroneal tendon tears, usually most of them, if you catch them earlier, you can repair them. And then for the ones that are really far gone, since there's 2 tendons there, you can repair it to the one next to it. And so this is a condition that, this is probably one of the couple of conditions of foot and ankle where I think an MRI is very helpful. And so for pain on the outside of your ankle, sometimes an MRI can help you. And it can make the diagnosis of these tears, and it makes your decision making a little bit easier. So that's the 3 most common tendon problems around the ankle that I see. Does anybody have any questions about that? Yes, sir. He asked what we think about the rocker sole shoes. And so in general, I like them for some specific problems. We used to, for people with ankle arthritis, or if they've had a arthritis through the middle of the foot, or anything that decreases the up and down motion of your foot. Having a rocker sole helps you substitute for the motion that you've lost. And so in those situations, it's very helpful. They got marketed a lot. The Skechers was the real popular brand initially, and it had a pretty severe rocker, and so they marketed it quite a bit. And did you ever try them on? Yes, of the Skechers. So the thing about the Skechers was the middle part of it is really soft and squishy, and so some people like having that extra cushion. And in the hospital for a while, it seems like all the nurses and things go through a lot of different fads because they're on their feet all the time, and so they were pretty popular for a while, just for people with heel pain, and I think it worked for some people. The reason they got into trouble, they took them off the market, was I think they were promoting them as a way to, lose weight and change the tone of your legs and doing all these things that I'm not sure people agreed with. They didn't, so they pulled it off the market. But just the concept of a rocker sole, I think, is very helpful. Like if you go to a shoe store or something like that, you'll find a lot of different brands have those rocker soles. And so you can still find them, and they're pretty popular for a lot of different problems. Yes, ma'am? No, I don't think so. I think probably the only place where it might be harmful is if you have any balance problems, you probably don't want a real severe rocker. So, just kind of just a little bit in the front and the back is okay. But otherwise, if you don't have any balance problems, it's okay. Yes? Clogs? I think if they're comfortable, they're fine. I mean, usually that's kind of in a real simple way. I had a teacher one time that said when people come in with sore feet, tell them to go out and walk a bunch and get your feet really sore and then go try on shoes. So you find ones that feel comfortable on your feet. But the clogs, I think, are, when in the open back sense, are really helpful for Achilles tendon problems. Yes, ma'am?
What about the barefoot or the minimalist shoes?
The issue with the again, I think if they're comfortable, it's fine. I think the problem with the whole barefoot running craze and everything is that it kind of came out of, there's this book that this guy wrote about barefoot running, and those people are these people who live in the mountains and they run barefoot their entire life, and so their feet are adapted to it. So if someone like me decided to take up running, I've been wearing shoes for the last 50 years, and you start running barefoot, my feet are probably going to hurt. So I think if you have, I mean, the whole theory is that if you're barefoot, you use all the intrinsic muscles of your foot, and then it helps maintain the general health and alignment of your foot because you work all those muscles. But so I think in general, I think a good supportive shoe is probably good. I would enter into the barefoot part with some caution, or I wouldn't. Yes.
On a baby, okay, they're just like in socks and stuff. And then, so when that child starts walking, is that when you put them in a shoe? Or what would be the best thing for their feet?
You can't. Most of the studies, as long as the baby's otherwise normal, like putting them in an arch support isn't going to give them an arch if they weren't going to have an arch to begin with. As far as when to wear shoes, I think you put them in shoes when they start walking just to protect their feet so they don't step on things. But I'm not sure if I'm answering your question all the way, but
I guess what I'm trying to ask is there a benefit to not wearing shoes up to a certain point for the foot as far as development and, like on a baby or something like that? Is there an advantage to the foot by not?
by going barefoot more?
Yeah.
I don't know. There might theoretically be one, but realistically, we live in a society that wears shoes, and so kids probably going to wear shoes at some point. Yes, ma'am.
The first type of ligament problem,
Uh-huh.
tendon problem, with with that surgery and the pins that you put in the ankle, what's the recovery time for that?
For
Is there surgery
the
done?
posterior tibial tendon reconstruction. Usually you're, for the first probably 6 to 8 weeks, you're in some type of boot or something, and you're not really putting much weight on it. So the first 2 months is probably the toughest. After the second month, you start putting weight on it. Hopefully by the third month, you're putting a shoe on. And then what I usually tell people is, so most people who are having this are adult. They work and have a job and everything. So your biggest restriction is in those first couple of months. Now, depending on what your job is, I mean, if you're a job where you're in an office and you sit down all the time, it's not a big deal. If you're a nurse or you work on an assembly line or something where you're on your feet for 10 or 12 hours a day, it could be 4 to 6 months before you're really ready to do something like that. But usually you're pretty functional and starting to get in a shoe about 2.5 to 3 months, and hopefully all your crutches and cane and all that stuff are gone by 3 months. But probably the only other point, and I don't mean to scare anybody away if you're thinking about having surgery, but it takes a while to get used to the realignment of your foot. And that's usually what I tell my patients, is that you're going to change the alignment of your foot, and the whole goal of the surgery is first to keep the deformity from getting any worse, and second, it takes a while. When you realign those bones, your bones have deformed over time, and it took you a while to get there, and after you change all the alignment, it takes you a while to get all the way back. But I usually use my wife's grandmother as an example. She got terrible flat feet, and I remember, I've been married 20 years now, and so back when I was dating my wife, and I was doing my training, they said, come look at my grandma, and I'm like, you got bad flat feet, and maybe you ought to get it fixed. And I'm like, no, she just had her knee replacement, so she didn't want to go in. Well, she's still alive. I mean, she's 90 years old now, and she can't walk because her feet have completely come off the ends of her legs, and so the deformities do tend to get worse if you don't do anything about them. And so, in the greater scheme of things, you have to think, I mean, people's life expectancies and the length of time that they're staying active, I mean, you can't really just say, well, you're 68 years old, you're probably going to die in a year or two, don't bother with it. So people are living much longer, and they're much more active, so you want to try and make your activities pleasant. Yes? How about you back there? Plantar fasciitis is pain on the bottom of the heel, so on the surface that's hitting the floor. And if I knew the cause, I probably wouldn't have to be here. I'd be really rich. I wouldn't be working anymore. The cause really is same thing that the other cause. The plantar fascia is not a tendon, but it's a soft tissue. It attaches on the bottom of your heel. So the plantar fascia attaches right there on the bottom of your heel. And so there's your Achilles tendon where it goes in, and the plantar fascia is right there. Plantar fascia also helps support your arch. And so again, the most common presentation is in middle age. That attachment, right where it attaches to the heel, starts wearing out, and it starts breaking down some. And I don't have an answer of why it's so painful. But it's painful. The thing, if you have it, the thing you have to keep telling yourself is that the natural history of it is that it goes away. Most of the treatments that you're doing are basically just to treat the symptoms until it goes away. So you got to be careful with the treatments you choose. So some of the people that you don't want to be the guy that gets surgery on it and then you're worse off than you were before. You got to be a little bit careful with the cortisone shots. The studies that have been done on the cortisone injection show that it gives you a little bit of short-term relief, but it doesn't change the natural history of the time it takes for you to get over it. So the biggest study that I usually quote to people is that if the treatment for it is basically symptomatic. So you take Motrin or Tylenol for pain. You use some type of cushion or arch in your shoe. You do stretching. Physical therapy is helpful because of the ultrasound. And occasionally people will try night splints or something that keeps you stretched out at night. If you do all that, the natural history is that 95% of the people get over it within 11 months. Now, 11 months is a long time.
Necessary to stop and rest it, or can you just continue, if you can tolerate it, is it okay just to keep going?
I mean, I think it's just okay to have some pain when you're doing things. You shouldn't be, miserable the nenext day. And so to try and push through the pain is probably okay, but I don't think you want to push yourself to where you can't do your normal activities. Most important, the other part of the stretching, though, that the people have shown makes a big difference when you go to the therapist. Usually they have you stretching your calves, kind of doing this. The other thing you need to do is can I demonstrate on you? Keep your foot up there. So you take your foot, just put it on your knee. Okay? Take your foot there, and then you grab your toes, and you pull your toes up. So you're really stretching the arch of your foot. And then you can take an ice cube or some type of ice massage, and then you just massage there. And that's been shown to make a difference better than just regular calf stretching. Mm-hmm. Yeah, I think what you find with a lot of these tendon problems and massage is that massage and a lot of the different types of physical therapy is it just increases blood flow. And increasing the blood flow is good. So, yes?
With the plantar fasciitis, do you do more damage still exercising with the pain if you can tolerate the initial 5 minutes of warm-up when it's the most painful and then it seems to go away? Do you do more damage to the fascia?
Probably not, but I usually try and get people to do, like if you're a runner, I usually try and get you to cross-train or do, get on an elliptical or a rowing machine or something where you're not doing impact. And so it's good to cross-train a little bit. Yes, ma'am. Shin splints is a real generic term, kind of like back pain. So shin splint, probably the worst thing you want to make sure you don't have is a stress fracture. So if you have that, that pain on the front of your leg, it probably warrants getting an X-ray and making sure you don't have a stress fracture. The other causes of it are this posterior tibial tendinitis that we talked about. Sometimes that's a cause of it. And then sometimes people can just get an inflammation of the covering of the bone, which is called a periostitis. And it's usually related to activity. And again, it seems like the people who complain of that the most are people who are big runners. And so again, when you're rehabbing them, you try and get them to change the surface they're running on. You might change their shoes. Some people use those elastic strap or sleeves. Get them to swim and bike or do other things so you don't have the same pounding. But it's generally an overuse syndrome. You're probably on crutches for 4 to 6 weeks, hopefully back in a shoe by 2 to 3 months. You're doing for all the Achilles tendon surgery, we have a real regimented rehab protocol where each week they give you a little bit more to do. Like in the first couple weeks, you might be on a stationary bike, and then kind of you build up. And so usually by 2.5, 3 months, you can do light jogging on a treadmill. Yes, ma'am.
What happens to a tendon that tears and then snaps off and winds up in your calf?
Like one of those old window shades? Yeah. She asked what happens to a tendon that tears and then winds up in your calf.
If you ever fix it, how can you get along without it? Because that's what happened to my leg. I felt like someone had thrown a rock. It was a sharp pain, and then there was a knot in my calf. And
Can you hear her back there?
I went to a chiropractor, and he said that a tendon probably broke down there, and it's rolled up. I never did anything. The pain went away. So what happened to that tendon? How can I get along without it?
Don't eat anything tonight, and I'll meet you tomorrow, and we'll fix it. So, people can walk without an Achilles tendon. Probably where you would notice it most is in fast walking, if you do any type of sports or jumping things. And you probably notice that you can walk okay, but it definitely changed the way you walk. Would that be true enough?
Every day.
Right.
So I don't really notice it, although I stay sore. Both of my legs stay sore.
And is one calf a little bit smaller than the other? Yeah. So there are certain people, not everybody has to have, when you rupture your Achilles tendon, and it's done more in Europe than it is in this country, but not everybody needs to have a complete rupture, which is probably what you did. Not everybody has that repaired. And there are certain ways to rehab somebody non-operatively. In this country, most people who are relatively healthy and active usually get it fixed. And I usually talk to people about both sides, but I think your recovery is more predictable if you fix it. So some people, like you, you've ruptured it and you kind of did okay, or you don't notice it that much. It's hard to tell when you see somebody, like you come in and you just rupture your tendon last week. It's hard to tell if that person is going to be like you, or if that person is going to have pain and walk all the time with a limp. And so it's a little bit of a judgment call, and you kind of talk to people about what their activity levels are, talk to them about the risks of the surgery, and then a lot of times they just kind of let the patient choose.
Another question, I have high arches, real high, and there is a knot up in the arch. Would that be like a tendon wearing? Because there was a picture up there with those knots. Would that be what that is?
In your arch?
In my
Sometimes you can have those nodules in your plantar fascia. And the plantar fascia is that, when you pull your toes up, you feel that structure kind of tighten up in your arch. That's your plantar fascia. And so sometimes you can have nodules in there. It's called plantar fibromatosis. Usually you don't need to do anything about it unless it causes pain.
Also, I wondered if you was going to cover diabetic foot problems tonight.
Nope. That's a whole other talk, but diabetes is very common, and the main thing I would tell you is that from my standpoint in orthopedics, the biggest thing that causes a lot of problems is that with diabetes, oftentimes you lose the sensation in your feet. And as you lose your protective sensation, those are the people that start getting ulcers. So if you do all the things to maintain your circulation, there's ways that your circulation can be improved. We don't really have a good way to prevent you from getting the neuropathy or the loss of sensation. And probably the best thing or the best advice is to first see your primary care doctor and get an early diagnosis, and the second thing is keep your blood sugars under as tight a control for as long as possible, and that's probably the best thing you can do to prevent the neuropathy. But if you're diabetic, you need to be looking at your feet every day pretty carefully, and diabetics don't heal wounds the same way non-diabetics do. They have more problems healing wounds, and so a small blister or a little cut or something that you think is pretty minor, you have to take it very seriously and treat it very aggressively to get it to heal. And
what is the aggressive treatment?
well, I mean, it depends on how deep the ulcer is and where the location is. But in people with trouble with sensation, the biggest thing is you got to stop walking on your foot. So if you got an ulcer on the bottom of your foot, it's a pressure ulcer. Just like people who are laying in bed get a pressure ulcer. It's a pressure ulcer on the bottom of your foot, and the only way to get it to heal is to get the pressure off. And so we have wound clinics and things that we work in that have different methods of getting the pressure off of that. So you can do it with a cast or some of these different braces or things like that. And so you've got to get the pressure off the area in order for it to heal.
One more question. Once that neuropathy has happened, is it possible
No.
Oh.
But you can live with it. There are, and when you say reverse it, the problem with neuropathy that people see is a lot of times people have symptoms related to it. So you got this numbness, burning, these funny feelings in your feet, and there are medicines that can dampen that. As far as taking some medicine that restores the sensation in your feet, there isn't anything that does that. So you have to figure out how to live with it and how to prevent the things that that can cause. So usually once you have neuropathy, you got to be pretty careful with the shoes you pick, and also if you have any deformity in your feet at all, it's good to use molded inserts, like a softer molded insert that goes inside your shoes. Yes, ma'am, back in the red.
Have you treated anyone with, I think it's pronounced talus valgus?
That's a bunion.
Bunion with
Yep.
in the toes or?
Yes. It's very common. Again, the easiest thing you do is get shoes that fit your foot better, and so it's not symptomatic. But as far as treating it, you try and modify the shoes first, and if that doesn't work, there aren't a lot of non-surgical treatments. As far as you can't really put something on the toe and hold it straight. That may help your symptoms a little bit, but as soon as you take that off, the toe is going to go right back over. And so there are surgeries to correct that. And what's that?
How long is the surgery?
Depends on how well you do the correction. I mean, there's a fairly high recurrence rate in bunions, and I think the reason that is, again, that's a whole other talk, but the reason there's a high recurrence rate is I think because people undercorrect them to begin with. And so you say, why do people undercorrect them? It's because a lot of the people with smaller deformities are younger people and they're trying to get back to work. So they do a surgery that's a smaller surgery so they have a quick recovery. And sometimes that'll help your symptoms for 5 years or so, and then a lot of people, as you get older, your toe starts going back over again. So if you undercorrect the deformity, you have a high chance that it's going to come back. But if you correct it all the way, it does very well. Yes?
How about the pain in the ball of your foot? What does that occur and how do you treat it?
Pain in the ball of your foot, like under your big toe?
Not under my big toe.
The second toe? Yeah. Usually it's related to the joint, your metatarsal phalangeal joint or MTP joint, where the toe meets the foot. And as that gets tender, usually people with longer metatarsals have more pain because that's the area where most of the pressure concentrates when you go up on your toes. And it's kind of the first stage of a hammer toe. That joint gets irritated. The treatment for it, for the most part, if you get a good arch support, you can usually relieve a lot of the symptoms. And then if you don't have any, if you have a deformity of the toe, there's some little things you can put in your shoes that kind of, if your toe's getting cocked up like that, there's some things you can put on your shoes that'll let your toe lay down, and then that redistributes the weight off the pad back into the arch of your foot. So if you don't have a big deformity and you're not having trouble with shoe wear, usually you can treat that with inserts or some type of arch support. Yes?
You mentioned a little bit non-operative treatment with the PRP. What kind of recovery? Will you take the plasma, inject it in there? What kind of recovery period and what's the success rate for that?
We're trying to answer both those questions with our research study. I would say most of the people who get better within probably a month to 6 weeks. They're seeing a difference. We don't really restrict them a lot. I mean, obviously it does hurt some to get a needle jabbed into your Achilles tendon, but so I usually tell them, again, we do it on Friday afternoons. I tell them put ice on it and kind of take it easy for about a week, but I don't really restrict them more than that. There's no boot or brace or anything you have to put them in. And the success rate, the way our study's working is we have them fill out all these pain scores before they do it, and then we get pain scores at 2 weeks, 4 weeks, 6 weeks, 3 months, and a year. And the success rate, I guess I would say, of all the people we put in the study, I haven't had to do surgery on any of them. So most of them say, you know, there aren't people that are like giving me a big hug at 2 weeks and saying this is the greatest thing I ever had. But on the flip side, most of them are saying they feel better, 50, 60%, and they feel better to the point where they're not going to physical therapy, they're not doing a shoe modification, and they're not wanting to do surgery. So what we're going to find out, we're going to try and follow them for a while and find out whether it's a lasting effect. But for the cost of one injection and no hospitalization and no surgery center, it's a pretty and there's really no lost time from work. So I think it's a reasonable option. Yes, ma'am.
If you get pain in your heel and lower leg, should you avoid stretching?
No. Like in the back of your lower leg?
Yeah, but you have sometimes when you're walking or sometimes
Yeah.
it's in the heel and goes up into your ankle.
Yeah, like along your Achilles tendon? Yeah, no, stretching's good. Just gentle stretching. Yes. Yeah, for Achilles tendon problems, one of the big things we try and promote is a thing called negative stretching. So it's basically like, if it's my left foot that's affected, you stand on a step, you go up on your toes on both feet, and then you shift all your weight over to your left foot. And then you got all your weight on your left foot and you slowly go down. So that it gives you an eccentric contracture of the muscle, and the theory is that it's supposed to be better for the tendon. Yes, sir.
I'm looking for a clue, college runner that I coach, foot swelling after hard workouts or after races on the anterior side, on the side of the foot, swells up for 24 to 48 hours. I know he's not got gout, but I don't know what he's got. I don't know what goes on. He runs better in a minimalist shoe or barefoot. If he wears a supportive shoe, it aggravates him.
It's on the top of his foot?
No. From the ankle down to the side of the foot on the anterior side. I've never seen anything like it, and I've been in the sport a long time.
No change in alignment of his foot?
He's fairly well, biomechanically, he's very
Yeah.
good. But if it's hard effort, his feet swell up.
Both feet.
It will affect both feet, yes. And I have no idea what's
And this is like a collegiate competitive runner?
right, exactly.
Yeah. Does it ever prevent him from running?
Yes, but it curtails his training for 24 to 48 hours.
Yeah. I mean, I'd probably just cross-train him as much as you can until he's ready to.
For a clue to what would cause swelling.
I don't know, some type of overuse problem. Yeah, obviously it's related to his running, and so I'd probably cross-train him as much as you can, and especially if it's in both feet, that kind of goes against a injury.
And he has little discomfort barefoot or minimalist, and it sounds backwards, and he has more discomfort in a supportive shoe. It's crazy.
Get him a bike.
Yeah.
I think you stumped me on that one. Yeah, yeah.
Thanks.
Yes, ma'am.
What would be the recovery period for the house phase surgery, and what's the success rate?
In general, if all you're doing is the first toe, usually I tell my standard answer is it takes you about 2.5 to 3 months to get back in a shoe full-time walking. So usually you're kind of protected weight bearing with crutches for about the first month. You start putting more and more weight on it. By 3 months, you should be in a shoe. And again, the success rate is all related to the initial correction you get. And so and I think the struggle in making your decision on a surgery is that depending on the deformity, I mean, you have to choose a surgery that's going to fully correct the deformity. And you got to be realistic. And so I'm not one of those guys that tells people, hurry up, have this surgery and you'll be back at work and running in a month. I mean, it's not really worth it to go through the surgery if you don't fully correct it. Otherwise, you're going to be doing it again in 10 years. Okay. Oh, yes.
Is it okay to take those pain medicine often, such as ibuprofen?
I think the ibuprofen is mainly for pain. I think the anti-inflammatory effects have probably been over promoted. So I don't think if you're, it's not going to help you with swelling and things like that. The main reason you take it is for pain. The main risk is stomach problems. So you got to be careful if you're prone to get an ulcer in your stomach, or you have stomach upset or reflux or things like that. You got to be careful with the anti-inflammatories. But it's generally, it's probably one of the most common medicines prescribed, and it's pretty safe to use. I mean, kind of your go-to things are Tylenol and Aleve, and Motrin. You can't take Motrin and Aleve together. They both kind of do the same thing. Tylenol is a different kind of medicine, and so you can mix Tylenol with Motrin. You can mix it with Aleve. Don't mix Aleve and Motrin. Okay. Yes.
How often, I imagine this doesn't happen very often. Surgery, we'll say ankle surgery, and it doesn't heal after the surgery. Do they know why that happens? Or
You mean the wound doesn't heal, or
the bones don't heal, or it just doesn't heal, the person can't walk?
was it like surgery for a broken ankle, or?
Yes.
There's a lot of reasons sometimes why bones don't heal. Some of it has to do with the severity of the injury. It has to do with how it was fixed. Sometimes the alignment of the foot can affect whether it heals or not. Most ankle fractures heal. Probably the biggest problem we have with ankle fractures is that people are a little bit stiff afterwards, or a little more prone to arthritis. But if it doesn't heal, I think the first thing you got to look at if you had surgery is how you fixed it. And sometimes, either you didn't put enough screws in, or you didn't fix it stable enough for the bones to heal. Diabetics in general have more difficulty healing bones. So there's some medical reasons why fractures don't heal. That I would think that would be unusual. So there should be some reason that you want to look for that's somewhat fixable, so they can walk on it. Yes.
Are any of your surgeries microscopic? Are they all major surgeries?
In the foot, not microscopic in the sense you use a microscope to do it. No. The microsurgeon, the main areas those are used, it's used a lot in spine surgery. It's also used a fair amount in hand surgery, or where you're reattaching vessels or things like that. Some of the things, I'm not sure if you meant arthroscopic, means that's a way of looking inside joints. And so we do, in foot and ankle, you do mostly in the ankle, you do arthroscopic surgery, but not necessarily microscopic. All right. Well, thank you again for coming out. It's been a pleasure to talk to you. Usually when we have these things, there's always leftover food, so grab a bottle of water and a cookie for the ride home, and that way we don't have to take them out. But thank you for coming, and if you have any questions, I'd be happy to talk to you later.